Ladies and gentlemen, dear colleagues, welcome to this session in the main arena titled Modern PCI, How Physiology and OCT with the new Ultreon software support you in guiding and optimizing the procedure along diffuse lesion. The session is sponsored by Abbott. My name is Joel Pirot. I'm an interventional cardiologist from Budapest, Hungary. Together with me moderating this symposium is Professor Emanuele Barbato from Naples, Italy. We have a distinguished panel as discussants of the case, Dr. Carlos Collet from Belgium, Dr. Niels van Hooyen from Nijmegen, the Netherlands, Dr. Tomaso Gori from Mainz, Germany. The chat master, importantly, is Dr. Antonio Maria Leone from Rome, Italy. At this stage, I would like to encourage the audience to interact with us by way of placing questions via the chat. The flow of the session is as follows. Shortly, we will be showing you a recorded complex LED intervention performed by Professor Barbato and Dr. Collet from Aalst, Belgium, a world-leading center in coronary physiology, as well as intracoronary imaging with pre- and post-PCI physiology and imaging using PressureWire X from Abbott and the CoroFlow software that I'm sure many of you will be familiar with, as well as the brand new Ultreon OCT software from Abbott that has a number of features, making it extremely user-friendly and a degree of automation appealing both to the experienced and relatively unexperienced operator. First, we will see the diagnostic part of the case, followed by 5 minutes of Q&A, then a lecture by Dr. Tomaso Gori with the title, Sending a Patient Home Confidently, the Prognostic Value of Post-PCI FFR and/or an Optimal OCT Result, again followed by live discussions triggered not only by the questions of the panel, but also those of the audience, communicated by the chat master. And finally, we will be shown the treatment part and the post-PCI evaluation of the case. Without further ado, I would like to ask my colleagues in the studio to show the case.
Thank you very much, Jolt, and welcome to the Cardiovascular Center Aalst. My name is Emanuele Barbato, one of the interventional cardiologists here. And without further ado, let me hand over the word to my colleague and friend, Carlos Collet, who will introduce the team and then the next steps of the procedure. Carlos.
Thank you, Emanuele. Yeah, so we're here, the complete team. We have Professor Barbato, who's going to be the first operator for this case. I'm going to help him with the physiology and imaging. We have our interventional fellow, Giuseppe Esposito, and of course, the whole team behind us, and else on the table helping us.
Thank you, Carlos. We propose to you a 70-year-old man with the common risk factor, diabetes and COPD. He came to our hospital with a typical chest pain. He had normal left ventricle function, normal renal function, and positive exercise test. Coronary CT scan, we can identify the right and the left ostium, coronary ostium, with the posterior takeoff of the left main, and as you can see on 3D reconstruction on the right, a long calcified lesion on the LAD with a very short left main. And multiplan reconstruction confirmed the concentric calcification on the mid part of the LAD and also the length of the lesion held from 75 mm. The FFR CT confirmed the positive value on the distal part, as you can see also drip of the pressure curve in the middle part. The ideal projection based on CT scan is LAO 43 and cranial 37. The FFR on the circ is borderline. LV angiography confirmed the data by echocardiography with a normal left ventricle function. Non-dominant right coronary artery free of disease.
Okay, thank you, Giuseppe, for presenting the case. So what is the plan for today? We plan to do a fully imaging and physiology-guided PCI. We're going to start by measuring, of course, distal FFR. We're going to complement the single-point FFR with a pullback and the calculation of the PPG to understand the pattern and help us guide the PCI strategy. Then we're going to understand the morphology of the plaque by doing an OCT pre-PCI. We're going to implant our stent, and then we're going to check the result of our stent by a post-PCI OCT. And finally, we will do a post-PCI FFR with a pullback to understand the degree of functional revascularization. And we're going to go now to the angiography. This is ERAO cranial, and you will see that the LAD has a long disease from the proximal and mid segment, and actually in the distal end of the vessel becomes normal. So we're talking about a long calcified disease in the proximal and mid LAD. We're seeing already there is some calcium in angiography, but we're going to further refine that analysis, of course. And here we see an LAO cranial with more or less the same information. There are 3 diagonal branches. These diagonal branches are small. We have quantified the myocardial mass with CT, and these are small territories. So I think that the strategy that we have defined together with Emanuele is to go to image the LAD to be sure that we don't need to do any additional treatment that concerns calcium.
As you see, we are ready now with the pressure measurements of the LAD. So the pressure wire is already at the tip. We are ready for the equalization. We can perform the equalization again. There we go. We have a 1. So I will insert again the needle in the hemostatic valve here. You know, when we do this exercise, what we like to do is flush the guiding catheter with, from any residual of contrast medium. There is some tortuosity there. I will do very gentle movement. And of course, there are lots of septal branches and diagonal branches on the way. We try to avoid visiting all of them. There we go. I think we are good enough.
Good. So we have positioned the wire distal in the vessel. Now we're going to proceed to measure FFR. I'm going to flush the system with saline. This is to obtain high-quality pressure tracings, and this is an important step to avoid artifacts in the pressure tracing that can affect your FFR measurement. So I'm going to start with the administration of papaverine. You see here that is completely transparent because we have not mixed the papaverine either with contrast or heparin. Then I'm going to prepare to administer 12 milligrams of papaverine into the left coronary artery. This is approximately 3.5 cc in our dilution. So I'm going to take here the time to look at my line, and I said 3.5 cc's. This is going to be enough. Now what I'm going to do is I'm going to push this with saline, and then the patient will be hyperemic for about 1 minute. And in that time, Dr. Barbato will perform the pullback.
Start.
Start pullback, please. So we click on the pullback button. Now Emanuele is making sure that the pullback speed is constant and that he have a stable pullback until the tip of the pressure wire. And you'll see immediately how there's a big jump in the mid-LAD and some diffuse disease in the proximal LAD, and we're going to be prepared to click on the stop button as soon as the sensor reaches the catheter tip, which is now stop. And look at this pullback. This is a perfect pullback. You see that the morphology, there is no artifacts, and you see immediately we calculate the PPG, and in this case, the PPG is 54. But if we go beyond that and we look at the red mountains below in the coroventis, we see that there are 2 places where the pressure is being lost. In other words, there are 2 places where there are significant lesions from the functional perspective. In the mid segment is the worst lesion, is the one that we see in angiography in the mid, but there are also some diffuse pressure losses proximally. And when you see the physiology in this case corresponds pretty well with the anatomy, Emanuele.
It's perfect. So what I learned from here, Carlos, if I understand it well, is that first we can help this patient. There is some focal functional disease that we can certainly treat effectively with a stent. Most likely we will need a long stent, but this I think we will know more after the OCT pullback. So shall we move on?
Perfect, let's go.
So we are ready with the OCT assessment. The wire is already in. The OCT catheter is on the wire. Let's go. Yep. It's rather calcified and tortuous, so I hope the OCT catheter will slide through, Carlos. If not, we will need to do some. You see already this. We already have some buckling of the device. I'll pull it back a bit.
It's very proximal.
Yeah, indeed. But that's actually what I expected. So what I will do, I will advance the catheter a bit more and try again. So we are ready to give it a try again after rotational atherectomy, 125, 1.5 millimeter bar, non-compliant balloon 3.0. There is still a waste. Let's see if the OCT goes.
So here goes the OCT catheter. Okay, that's very good, Emanuele. Okay, so we're going to start with the OCT pre-stent implantation in this case, after having performed rotablation, simply because it was an uncrossable lesion with the OCT catheter. So we're now positioned that we need to use even a guide liner to put the OCT catheter in the distal vessel. And now we're prepared to take the first acquisition to understand a little bit more what is the pathology behind this lesion. So this is the first screen of the new software, of the Ultreon. So you see it's only telling you which type of pullback. I'm going to select 75 millimeters. We're going to see a long part of the vessel. I'm going to click proceed. Then the software will ask us if we are happy with the amount of contrast in the vessel or blood. We're happy with this. So we're ready to go, Emanuele. We're calibrating and you can start. I'm going to trigger the pullback manual. That is a beautiful pacification, Emanuele. I think we have a very high quality pullback and we're going to be able to make a very nice analysis of the plaque. So the first step in this new layout of the software is to accept actually the quality of the pullback. So I'm just going to accept and continue. The next point is to actually inform the system where is the vessel to perform the co-registration. So I'm going to put a point in the proximal part of the vessel and I'm going to point another point in the distal part of the vessel, and we will just have to check the center line that actually goes in the path that we have selected, and this is correct. And you see that I'm going to confirm now. And then the co-registration is being performed. So now we're going to start our analysis, and just for all of us, or for the ones that are starting in the imaging field, it's very easy to go through the algorithm of MLD MAX to understand the steps that we have to follow in order to assess all type of lesions. What comes in this new software, Emanuele, is that it helps us to identify automatically, based on artificial intelligence, the amount of calcium that we have in the coronary vessel. And that, if you see our longitudinal plane, and now I'm going to go into the OCT image, you see that is the typical OCT image, but in the longitudinal plane, you have new things. And these orange markers are just telling you where the calcium is more than 180 degrees. When I look at calcium, there are three things that I want to know. I want to know the arc, I want to know the thickness, and I want to know the length. These are the three things that can help us decide whether this patient needs an additional therapy, which in this case was already performed. So I'm going to drive you through the pullback, Emanuele. I'm going to start with the proximal part. This is the proximal LAD. Looks healthy from 3 to 9. But I have to tell you, Emanuele, that just at the level of the ostium of the LAD, I see a huge dissection. And this might be related to the use of the guide extension catheter. Then we go more proximally. Here you see at 270 degrees of calcium with a thickness of 1.3, but I'm pretty happy to inform you that there is a fracture of the calcium at 9 o'clock. Therefore, we're going to be able to expand our stent at this level. We further continue analyzing the plaque, and I'm going to go to the MLA. Here we see another dissection, probably induced either by the rota or the previous balloon dilatations, and this is the place where we were struggling. Emanuele, there in this specific spot, I have to tell you that we have no fractures of the calcium. So I see 360 degrees of calcium. The system is detecting 260 degrees, a little bit more, but that is because of the artifact of the guide wire. I have to tell you that the thickness, according to the machine, is 0.9 at the level of the arrowhead. So it's a thick calcium, circumferential, and it's more than 5 millimeters in length. So this is indeed where we're having so much difficulty getting the material down the vessel. So this is following the MLD MAX algorithm, the M of morphology. Now we're going to step to the next step of the algorithm, that is the L. It refers to the length of the stent and of course the size of the balloon that we're gonna use, or the stent. And this is the new layout of the Ultreon 1.0. You see again 3 cross sections. The first cross section refers to the position when the proximal landing zone is placed. The second cross section in the middle panel refers to the MLA or the MLD, and the last cross section refers to the place where is the distal landing zone. You will see here that the system tried to guide us, but indeed the disease is longer than this. So the first thing I'm going to do is to start looking for a healthy landing zone distal. And I have to go very distal. Here in the vessel you see at this moment, this dash white line is the indicator of EEL, and this is automatically assessed by the system. So in this case, the EEL in the distal landing zone is 3.09, meaning that we have to select a stent that is one matrix of the stent size below, that is 3.0. So that's the stent diameter that we're going to use. And I'm going to select this one as my distal landing zone. Why? Because all of this is full of disease. And then, of course, there is the MLA here, which is actually a ring of calcium. We will need to fix it before putting the next stent. And I would suggest that we need to cover this vessel until the very ostium of the LAD, mainly because there is a dissection in the proximal part of the vessel, probably induced by the guideline. So I'm going to select the length here, and the length at this cross-section, Emanuele, and at this level we have already EL to EL of 4.4, and that also informs me before I do my final OCT, what is the balloon that I have to select for the optimization in the proximal part of the vessel. So I'm thinking in the MLD algorithm, in the L, length, size of what, size of the stent, length and diameter, but also size of the balloon for proximal optimization, which is going to be a 4. And then I'm going to just place my second marker here, and we're talking about a region of approximately 63 millimeters in length, which is the necessary length to cover the complete plaque.
Dear Emanuele, Carlos, and colleagues, that indeed is a very complex and demanding case with a number of important teaching points. We could first appreciate the complementary role of non-invasive imaging, including coronary CTA and FFR CT, invasive physiology and imaging. Emanuele, am I right in having the impression that FFR has grown from being a pure diagnostic modality, a snapshot, so to speak, to a true guiding tool for our interventional, able to distinguish focal from diffuse disease, thereby helping the interventionalist in planning the procedure? Could you comment also on the PPG index, please?
We have also Carlos Collet, who developed this concept together with Jeroen Sonk. Well, I'm just borrowing some data and some concept that he thought to me. What PPG is telling us is informing on the geography of the functional coronary artery disease. So in a way, very practically, is telling us whether in a functionally significant stenosis, let's start from this background, PPG applies to functionally significant stenosis, so when FFR is below 0.8, and in this way we address also one of the questions coming from the community. So in that case, when we have a stenosis and FFR is below 0.8, what PPG is telling us on top is whether we can help these patients by implanting a stent, because we are dealing with focal atherosclerotic disease, and that is the case when PPG is above 0.5. At the variance with a PPG below 0.5, that is practically informing us that we are dealing with a diffuse coronary atherosclerotic disease. And in that second case, even if we implant a stent, it's very unlikely that with a segmental treatment, we can improve much the functional result of that particular PCI. Carlos, if you want to add more, just take over.
No, I think you captured the two main elements, Emanuele. So I agree with Dr. Pirot that we are moving physiology from a diagnostic tool that helps us decide whether we need to treat that patient, yes or no, based on the significance of the lesion, towards using physiology to help us guide and plan our interventions. So it's indeed a second dimension that we are adding to our physiological tools to help us do better PCI.
Thank you very much. Carlos, could you also summarize for us the new features of the Ultreon software in a nutshell in 1 minute?
Well, the major feature that has the new software is actually the automatic calcium detection. This is really helping you in the procedure to in a very fast fashion, assess the amount of calcium that you have in one place. If I would have to take one element, it will be the automatic calcium detection.
Thank you very much. Time is running, so dear colleagues, thank you very much for this instrumental discussion. And now I'm asking Dr. Gori to share his thoughts with us on when he can send or we can send the patient home confidently with an established prognosis after PCI. Tomaso, please.
Dear colleagues, thank you very much for the question and for allowing me to give a presentation at this EuroPCR. The question I'm asked to answer is, when do I feel confident sending a patient home after treating, for instance, a lung and calcific stenosis? And often those patients are also the ones that have multiple vessel disease. So let me just explain this in a couple of slides. This is my conflicts of interest with regard to this topic. And the first recommendation that I would like to make is, do not look for the aesthetics of the vessel. What is important is the functional significance of the stenosis. We know that if you calculate the syntax score in a patient with multiple vessel disease, you likely will have a worse scenario than if you measure the FFR in this patient. So, and what is really important for the prognosis of the patient is to treat the functionally relevant stenosis. This is something that we learned from the FAME study of 513 deferred lesions. Only one in 500 caused a myocardial infarction. From the deferred study, we have learned that treating a lesion that is hemodynamically not relevant actually carries a worse prognosis than if you don't treat it. So do not look at the aesthetics, but look at the functional relevance of the stenosis. We know that from a post-hoc analysis of multiple studies that both in patients with stable angina and patients with acute coronary syndromes, the residual syntax score after treating all the functionally relevant stenosis is really not relevant. So do not look at the aesthetics, but treat the functionally relevant stenosis. So the next question is, how do I define a good result in terms of functional improvement of the lesion? You may calculate, or you may just measure the PDPA just by reconnecting the wire after the PCI, or you may measure the FFR, the complete FFR. And this is a nice approach from the prospective PCI study. If you do PDPA alone, there is a good chance that two patients in 3 patients do not have a relevant stenosis. And if they do have a PDPA smaller than 0.92, there is a 50% chance that they will have a normal FFR. And only the patients with an FFR smaller than 0.8 had a markedly worse prognosis after PCI. So the relationship between mean post-PCI FFR and prognosis is, of course, linear. The higher the post-PCI FFR, the better the prognosis of the patients. And of course, you can take several cutoffs and the prognosis of the patients improves progressively. The goal that you may have is to have a post-PCI FFR larger than 0.90. And this is something that we can all share and be happy about. So what about OCT? There is an algorithm that you are, of course, aware of, the MLD MAX. This part has to do with the preparation to the PCI. This is what happens after the PCI. Medial dissection, apposition, and expansion are the things that you have to take care about. Just remember that in the PESTO registry, 97% of the lesions that cause the stent thrombosis could be or the reasons for a stent thrombosis could be detected at OCT. And this is the thresholds that you have to be aware of. If you have a dissection, this has to be smaller than 60 degrees. The flap has to be limited to the intima, and the extension has to be less than 2 millimeters in order to be a non-relevant dissection. Your minimum stent area has to be in the range of 4.5 square millimeters, and the malapposition has to be less than 0.4 millimeters in the distance between strut and wall. So just let me conclude. When to send a patient home confidently, aim at complete functional revascularization. Your threshold should be an FFR larger than 0.90. And the FFR, the higher the FFR, the better it is for the patient. And then use the MAX algorithm. Those are the thresholds that need to be kept in mind. Thank you very much.
Great, Tomaso. Thanks. Again, we see that the decision whether or not to embark on revascularization is a functional matter, and FFR has been established as the gold standard thereof. And now, as we see, it can also be used as a prognostic tool and important quality control of our result. I have a number of questions, but as far as I know, there are good and important questions arising from the audience. So, Emanuele, could you please share that with us?
Yes.
Questions we have on the chat.
Yes, Joel, thank you very much. Colleagues are excited about all our discussion and the case. Just a quick question, quick answer. What is PPG? It's nothing special, nothing exotic. All what you have to do is having hyperemia, stable hyperemia, put your pressure wire down and perform a stable pullback. PPG stands for pullback pressure gradient. That is what PPG is about. Having said that, one question, Jolt, for the colleagues. They are really impressed about the quality and the speed of processing of the Ultreon software. And they are asking whether this system can also quickly identify calcium fractures. Do you want to give this question to any of the colleagues?
Carlos, please, could you answer that for us?
I have to say that it's very fast with calcium, almost automatically, but the fractures, you have to look it by yourself. And not yet we are detecting the fractures.
Thank you. Anything else, Emanuele, that is burning from the audience?
No, I'm monitoring, take over the discussion, Jolt. I'll get back to you.
All right, thank you. So my question is, do we really have a gold standard post-PCI FFR to be reached in each and every case, or can we apply different cutoffs in different vessels? Niels, can you tackle that?
Yeah, I think
use it like 0.90?
That's a very important question. I think actually we should use these kind of measures. It's true both for physiology as well as for anatomy, so for the OCT parameters. At the same time, I think we should recognize that there is no validation for the use of these parameters yet. So there is also a potential downside by trying to get your FFR higher and higher, or your expansion levels higher and higher. So I think with the community, we have to think on how to perform a good clinical validation study. But I am convinced that that's the way we should head for.
Thank you very much. The higher, the better, we can conclude. But we don't know how high we should go.
Well, yeah.
You actually,
there's always a potential downside.
Yes, exactly. Actually, you were alluding to the expansion also, and that brings my second question. As for the MLD MAX algorithm, I find X to be the most demanding. So is it always possible to reach the target expansion, 80, 90%? Tomaso, Carlos, Emanuele, what do you think?
Well, of course, we know that reality is not the same thing as theory. There is a linear relationship between final FFR, expansion, malposition, and an outcome for the patients. So those are the goals that we have to keep in mind. Those are the thresholds that we know are associated with prognosis. Of course, in real life, we have to do the best that we can. There are massively calcific stenosis that cannot be dilated even with lithoplasty. So this is the goal, but it's not always to be reached in real life.
Yeah, maybe one other thing that we should, the way you can also use this is it's simply against superior to angiography. So what I have noticed many instances is that you do your post-PCI FFR and then it is very disappointing. But then if you take a second look at your stent deployment, then you see that you have, for example, focal either malposition or a residual stenosis. So I think we should also use it in that way. It helps us. It is helping us to recognize things that we don't recognize on angiography. At the same time, if you're you shouldn't go beyond what you can achieve reasonably. Because as I said, there is a potential downside. You can have edge dissections, you can have coronary perforations. So keep that in mind.
Yeah, and I couldn't agree more with you, because you actually are stressing the fact that these are complementary modalities. And I think if you have a lowish post-PCI FFR, the case is there for intracoronary imaging and OCT in particular to actually pick up why that is so. Is there a focal thing to be done, a post-dilatation, other stent, or a protrusion to be treated? Or do we really see it as a non-treatable diffuse disease that's left? Of course, hyperemic pullback at the end of the procedure is very informative, but intravascular imaging is really the thing to do to establish the cause thereof. Well, let's get back to OST, I think, and see how the operators tackle the case, and then we can continue our discussion.
What we're going to do now is we're going to switch to deployment mode in our Ultreon OCT, And this will help Emanuele understand exactly where he has to place the distal marker of the stent. Now the stent is there. Emanuele, so you see now that you have your live image in the Ultreon machine, and you have next to it the OCT with the white bar indicating the normal landing zone. So what you have to do is match this marker of your stent with the normal landing zone assessed by OCT.
Okay. So Carlos, the first stent is in. This 348 millimeters, what is OCT telling us with the proximal stent?
So OCT, first of all, I'm pretty happy, Manuela, that you landed exactly where the co-registration helped us to know where was the landing zone. And that also allows me to understand what is the length that you need to cover the proximal part of the vessel. So based on the OCT, you see there on the screen that we have now measured from where you have landed onto the very proximal part of the LAD, and it's about 22, probably a little bit more because we don't have the complete proximal part. So we're selecting 28, 30 millimeter stent, 3.5 for the proximal part of the LAD.
Excellent. Stents are in place. OCT catheter is at the distal landing zone of the stent. Shall we go a final pullback?
Perfect. You can start. Okay. We have three questions. The first question is, how are our edges, proximal and distal edge? How is the expansion and what is the MSA? And if we didn't have any gross malapposition. So this is our MAX algorithm. So I'm going to do the co-registration again to understand exactly if we need to do something else, we need to go. This is at variance with the previous software, first the proximal and then the distal. This is the new Ultreon feature. So my first assessment is going to be in the distal edge, where I'm going to look to see the transition. And in this case, we see a very nice transition without dissections in the distal part of the vessel. Then we are moving forward inside the stent, and I have used the dual reference technique for the expansion. And you see here how the new Ultreon calculates automatically the stent expansion, at least in the distal part, the distal half of this half of the pullback. So it's a bit complicated because of the two pullbacks, but I just want to bring your attention that in the distal part of the stent looks pretty well expanded. The system is telling me that this segment is 87. We have, again, following the MAX algorithm, the apposition looks pretty nice. I don't see any stent malapposition here. And we do have, in this very tough segment that we treated with the calcified plaque protruding to the lumen, is still some asymmetric stent expansion, and we will see that in the next pullback. Go for it. Go. Okay. So this is the post-PCI pullback. I see a couple of stents still with important malapposition, certainly more than 300 microns. Just at the start of the stent, here is a little bit worse, probably 500 microns here. So there are, at the edge of the stent, Emanuele, 5-6 struts that are not well opposed.
Is there any proximal dissection, Carlos, proximal to the stent?
No, there is no dissection. We managed to land exactly where we wanted, held by the co-registration. There is no dissection. You see that the transition is nice. Expansion is also good. However, there are a few struts that are not well opposed in the proximal part.
So a short post-dilatation there, and then we do final pressure gradient assessment, and we're done.
Perfect. And I think we should go with a 4 semi-compliant balloon because we don't want to post-dilate, we just want to oppose now.
Okay.
Okay? Okay, so we are now ready to assess the physiology of this vessel after PCI, and Emanuele just crossed again the stent with a PressureWire X. So we're going to induce hyperemia with papaverine. So that is Giuseppe's putting the papaverine, and this is the easiest way to induce hyperemia in the cath lab. Then we're going to wait 10 seconds, and 10 seconds Emanuele is going to start the pullback simultaneously with the Coroventis machine. So Emanuele is steadily pulling back the wire. You see here that there was a small step in the distal part of the vessel. Now we are inside the stent. This was the region that was with the calcified plaque.
Stop.
Okay. Okay, Carlos, I think we are done here. We'll have time to discuss the case with you in the studio. So back to you, Jolt. We'll see you there in a few seconds.
Emanuele Carlos, what a masterful demonstration of a highly demanding case. Could you summarize what the two complementary tools, physiology and imaging, made you change in your treatment strategy?
So if I may start, I think that the OCT helped us understand exactly what type of pathology we had. We were really aggressive to treat this calcium. It was a concentric ring of calcium. And without having done a good preparation of the vessel, we will not be able to achieve the functional vascularization that we had, and neither the expansion that we achieved. So this is a very important step in the whole PCI process, to understand the type of disease and do your best to achieve a big extent expansion. Of course, confirm that by post-PCI physiology.
Anything to add from your part, Emanuele, on that? Maybe the pre-PCI functionality and diffuseness of the lesion?
Well, let me bring in several points from the colleagues. Massive discussion going on in the chat. So more than to bring in my personal opinion, I'd like to focus our attention, if you agree, on the points that comes from the community. Well, one short one: tips for OCT after passage. Tips for OCT catheter passage after stent implantation. This colleague finds it difficult sometimes. You've seen it. We had a lot of troubles to advance this OCT catheter in the coronary artery. Even before implanting the stent, we helped ourselves with the mother and child catheter. Post-stenting, you can also use a parallel wire technique or pull-push technique with your wire. That's number one. It's an easy one. Number two, I find it interesting, Jolt, you decide to whom give this question. Post-PCI FFR assessment, is it necessary even after a good imaging result? So you have a good OCT result. Do we still need to do post-PCI functional assessment?
That's a good one. Who wants to take it? Else?
Yeah, I think, well, we've discussed that before. So I think not for the stented segment itself. So if you have an OCT and you have a nice result, don't try to go beyond that, because as I said, you might regret it. But what it might be helpful for is looking at the rest of the vessel, because sometimes you will see segments of the vessel that you have not detected angiographically, but then with physiology, you will see that there's residual stenosis. So in that case, also additional intracoronary imaging might help, or do your pullback.
I have others here, Jolt.
Exactly.
Yeah. So another good one that I find is how about physiology to guide spot stenting strategy? You know, I think this is very, very good question, especially if we discuss about geographic localization of the functional gradient. Perhaps this is for Carlos. How about this interaction between PPG as a tool to decide spot stenting?
Yeah, so this is a fantastic question indeed, Emanuele. And we have seen that there are cases with apparent diffuse disease in angiography, but that you find that the problem is actually pretty short and localized in one segment. And I think that this is the cases where the combination of imaging and physiology really helps you, because you understand where the pressure is being lost, and then you just need to find the sweet spots to implant your short stent. And we have done this guided by the PPG, and you obtain very, very high post-PCI FFR. So I think it would be indeed one way to look at PCI, considering not only the normal to normal based on anatomy, but also the normal to normal based on physiology. And these are concepts that we need to bring together to understand the interaction between physiology and anatomy with PCI.
Yes, I think, and what I have to add to this is that we also have some kind of an impression at the beginning of the procedure, what to expect at the end of the procedure. So if it's truly functionally focal, what we'll have is a good enough result, a large delta FFR, large change in FFR, and a high post-PCI FFR, if it's really focal. If it's longish, if it's functionally diffuse, then we may be able to get the FFR above 0.80, but of course, the change will be small and the post-PCI below, and most probably this patient will not benefit so much from intervention. And maybe this can be also an argument to go for surgery if it's very diffusely diseased vessel, especially in the LAD, which is graftable by the lemma.
Do you want one more question? Yeah, there is another good one. I think for equal distribution, the next one will be for Tomaso. This is a good one indeed. Any interaction between what we see post-stenting at OCT and what we measure with physiology? More specifically, the colleague is interested in knowing whether short part of the stent that are not well apposed or not well expanded, would this be also detected by the post-PCI pullback with the pressure wire?
That's an amazing point, actually. It's quite a smart question. It's smarter than one would think, and I'm not able to give a full response. Just remember that a drop in pressure is not only caused by the resistance of the stenosis, but also by the flow separation that occurs distal to the stenosis. So what you measure with the pressure wire is not exactly the same thing that you see on the OCT. So the answer is yes, and even an area of relative aneurysm may cause a flow separation that causes a pressure drop, as measured by the pressure wire. So the two informations are complementary, and they're both very very important. As of the struts, I'm sure that single struts will never cause a flow separation that is large enough to cause a gradient, but of course they may still be relevant, and they may still be seen at with the pressure wire as well. Yeah, of course, imaging is easier. Yeah.
Thank you very much, dear colleagues, Emanuele, Carlos, Niels, Tomaso. Thank you very much for this superb discussion of the two complementary modalities. I would like to thank our sponsor, Abbott, for making it possible to organize this symposium. I think we can all agree that we have seen a perfectly demonstrated complex case that had each step carefully planned and executed with a good result and precise prognostic information obtained at the end. We have learned today that FFR is not a black or white matter anymore. It's not one piece of information obtained before therapy as a part of the diagnostic workup, but also a very important and precise guiding tool in our armamentarium if performed properly with all the complex analyses made possible by the CoroFlow software and interface. FFR in its two-dimensional form informs us about the amount of pressure loss and its distribution along the vessel to be treated not only before, but also after PCI, and thereby giving prognostic implications and serving as a quality control. OCT, on the other hand, using the MLD MAX algorithm, standing for morphology, length, diameter, pre-PCI, and medial dissection, apposition, and expansion post-PCI, complements our information on the vessel to be treated before PCI and also thereafter. Ultreon is a great example how artificial intelligence is making it possible to convert a highly complex imaging modality into a uniform, easy-to-use, real-time tool, not only for the experienced operator, but I'm also sure also for the novice. And with that, I would like to thank you very much for your attention and wish you a great virtual stay in Paris. Thank you very much. Bye-bye.